are here. I might just wait another minute, actually, just before I start, just to give people time to wind their computers up, and actually for me to actually pull up the papers, which would be a good start, wouldn't it? Lovely. I think I will make a start, seeing most people I'm expecting are now here. Welcome to the November Primary Care Commission Committee meeting. Just as a reminder, if you could keep your camera on, it helps me rather than looking at the blank screen. And if you can keep your mics turned off to avoid interference. We also have joining us today Noah Vickers from the EDP. Welcome, Noah. And I forgot to say welcome to Sue from Health Watch Suffolk last time. And so belated welcome, but you were with us last meeting as well. So I'm going to move on to the agenda. We've got a chair's action that I took between the meetings in relation to the resilience funding allocation, and they're in the papers for your information. Apologies, we have apologies from Tracy Williams. She may join us partway through the meeting. She's in another meeting this afternoon for the ICS. Bill Borrett and Kath Byford, and I think there might be one of the officers might be joining partway as well, because they're in another meeting. So apart from that, I think that's all the apologies I have. Can I just remind everybody to keep their declarations of interest up to date, including your close family members? Are there any declarations of interest that is relevant to this afternoon's agenda that I haven't picked up anywhere? No. Silence I take as no. Thank you. On to item 4, which is the minutes of the last meeting, which is on page 20 of the pack. I'm sorry, I'm just scrolling through. Are there any matters arising or correction of accuracy in the minutes that anybody wants to raise? Rosemary.
Only just a quick one. I have mentioned it, Doris, but I was present. It shows my apologies, but I was actually present at the meeting.
That just needs altering in the final version before sign. Thank you. Thanks, Rosemary, for reminding me. And if there are no other items for corrections or matters arising, I will take the minutes as approved, subject to that minor amendment. And on to the tracker, action log. Most of the actions are now closed. I think I took the decision to take the terms of reference off the tracker because it's now not expected until 2022 approval from NHSEI, and has been added to the forward planner for us to keep track through there. And no doubt we will be reviewing our terms of reference at some point, depending on the new setup by then anyway. So that's the reason that one's closed. And I think all the others are closed apart from the last one, 83. And I think Fiona has sent an email just prior to the meeting, which answered Hein's question. And I think there was Hein was, I think you
so
shared.
Thanks, Fiona, for sending that through. I think it would be helpful for all the committee members to see that response. Maybe Sarah can do that after the meeting.
That's great. So we closed that one off, and Sarah will no doubt forward the email to the rest of us. I didn't have a chance to read it before logging on. So that's the forward planner. On to item 6, which is the risk register. Sadie, I think this is over to you. I love the new format. Thank you. It's much more readable.
Thank you very much, Doris. May I just check that you're content to take the forward planner as read?
Oh, sorry, I sort of mentioned it and skipped over. Are there any questions about the forward planner anybody wants to raise? No, so yes,
Lovely. Thank you.
Having skipped through it, thanks, Sadie.
So just moving on to the risk register then. As usual, I'm going to focus on the risks that are red rated, which are PC6, the learning disability health checks, and we have a paper later on the agenda on that showing some of the progress, and you've got a snapshot of the data on there as well. PC9, and apologies, the number is missing this one on the register, which we will correct for the next meeting, but that's hypnotics and anxiolytics. And you'll see that we haven't received an update on that risk this month, albeit that it is highlighted in the prescribing report, and I think everybody's well aware of our outlying position nationally on that, although it's improving in terms of the rates, because everybody's improving nationally, our rank, if you like, remains largely the same. I'm sorry we don't have more of an update on that this month, but we've had some unplanned absence in that team, which has impacted on capacity. PC11 is the risk around primary and secondary care interface, and you'll be aware that we have had now the first meeting of that group, which was I think everybody felt was pretty positive for a first meeting, and we have the second meeting next week. I think Lois is planning to come to the December meeting with a written report for members to consider. But in terms of what's happening at next week's meeting, it was agreed in the first meeting that we would develop an interface policy across the 3 acute trusts, which I think would be very welcome, and work has started on that and a draft has been shared. We're also going to be looking at the process for escalation of issues and improving the quality of referrals to secondary care from primary care, and we've also already agreed for the December meeting that the 3 acutes have an access policy, and there are a couple of areas in the access policy where the LMC has raised concern. And so we're going to have another look at the access policy at the December meeting. So really starting to tackle some of the knotty issues that have been around for quite some time. So clearly things are still causing concern, but I think it's a really positive that we've got the group in place. And that the engagement is high in this meeting. The LMC is represented on that meeting at the moment by the Vice Chair, but there is discussion about a practice manager member joining that group as well. And then whilst not rated red, I thought it would probably be a good idea, given all of the stuff going on in the press, etc. lately, that we should probably just give a brief update on PC13 and PC14, which is around general practice resilience and access. And I think colleagues are well aware of the workforce challenges right across the health and social care system, which obviously have predated COVID, but have been exacerbated by COVID. We are seeing increasing pressures in all healthcare providers through the rising rates of COVID and the impact that has on people as they catch it, or in healthcare certainly having to isolate if family members have it, which is slightly different to the general population. And so we've just spent a bit of time in a previous meeting being updated on the excellent work that's been undertaken by our comms and engagement colleagues for our primary and community campaign, which has been presented here before, and that should be going live in the coming days and will be a sustained campaign for the next 12 to 18 months. I think it's really important that that we continue to support our practices. They're not always able to provide the level of service that they'd like to be, particularly if they're being hit by absence rates within the practice. But it's really important that we still ensure that they're treated with respect. We also have a paper coming to the part 2 of the committee meeting on the recently published Winter Access Fund available for general practice, and the CCG, again, a phenomenal amount of work in a very short time by colleagues engaging with general practice, with LMC colleagues, and our own team to bid for around £4.8 million worth of initiatives to support access over the winter period, and think quite innovatively about different ways of, given the pressures on the workforce, different ways of increasing capacity and access in general practice. So we understand that our regional colleagues are meeting with national NHS England colleagues tomorrow to assess all the bids in our system, in our region. So we hope to be able to provide a progress update on that at the next meeting. So I think I'll stop there and just happy to take any questions along with my colleagues.
Thank you, Sadie. That's very helpful. Are there any questions for Sadie on the risk register? Nikki.
Sadie, if I may, can I just raise one comment about PC3, which is the LCS review risk? It's page 37 in the middle of the paper. It says gaps in controls or assurances and refers to the fact there's no LMC meeting in December. And that doesn't really have much bearing on the timescale because the LMC isn't using the full committee meeting as part of its LCS review. It has a subgroup which meets as and when the specs come through to us for review. So it just seems a bit wrong that statement is in there when it's not actually factual. Thank you, Sadie.
Thanks, Nikki. That's really helpful, and we'll amend that for the next meeting.
Thank you.
No, that's very helpful because it clarifies comments made at the previous meeting, which I think what the officers have put in that risk reflect previous conversations. So it's good to have an up-to-date position as to where we are on this. Are there any other questions, Hein?
Yeah, it's really a few comments. I like the new format as well, so thank you, Sadie and team, for putting that together. I made an observation last time that most risks seem to be lumped around sort of the center of the visual, and these new overviews are helpful to demonstrate that the risks seem very static. So bar the LCS review that Nikki just referenced, which does change from time to time, the other ones have been in the same place for the last 8 months, and it doesn't feel sort of in line with the stories we get to hear in every meeting. So I don't have a solution for it, but more an observation that the team may take away and maybe apply a bit more dynamics to how risks evolve over the year. That's all, Chair. Thanks.
Thank you, Hein. It was just a question I had in terms of, you made a comment, Sadie, about access and part of the interface group. And I just wonder whether, with restrictions and visiting being reimposed at the acutes, whether there is a further impact in terms of communication between patients, their family, carers, and actually the medical team communicating with families as to what really is going on when, you know, that their loved ones might be a bit confused and not able to really communicate what care is being provided. Whether that's going to be picked up as that part of that access piece, because to me there is something a bit missing, I think.
Thank you, Doug. I'll take that away.
Yeah. Thank you very much. Are there any other comments or questions? Oh, John.
Yeah, thank you. Just an update on PC15, which was about the Wave 4B developments. It flags in there that there is a risk around NHSCI approval processes, which could put the delivery of the programme at risk. Just to say, we had the latest Wave 4B programme board yesterday, and that heard about some positive movement on that in terms of the approval processes. So whilst it's tight, we're still expecting to be able to deliver the programme on time.
Thank you, John. That's very helpful, because that's another one of these time constrained, and given what's happening in the construction industry as well, time is of the essence. If there's no other questions or comments, thank you, Sadie, for the update, and we look forward to the next update and hopefully we see some downward movements in risk. Or am I being wishful thinking, seeing it's December? On to item 7, which is update from the Director of Primary Care. Mark, over to you.
Thank you, Doris, and good afternoon, everybody. So I'll be fairly concise, and of course we'll take the paper as read, but my 2 items to flag really this month are items we have discussed before, but really build on some of the risks that Sadie flagged in her earlier report. So first of all, about the primary care campaign. I feel really positive about this. I'm really impressed with the work that the team have done. There's been some fantastic engagement, and we're very grateful to the feedback from colleagues at the LMC, the LPC and Healthwatch to make sure that we get this right. Just building a bit more on what Sadie has said, this is actually a programme between November and March. This isn't something we're just doing for 1 month. We're trying to help both patients and practices to make, with a library of assets and a bit of a toolkit to make sure we're getting those messages, the right messages out to support people, to support practices, support practice staff. It does go live this week, and actually just to give you an indication of we're going to be prioritising different areas as we go through the winter months. And in November, the focus is going to be about information around self-care and how patients can help themselves in those circumstances and where appropriate, but also the zero tolerance to some of the unfortunate and poor behaviour we have been seeing and had feedback on from patients when frustrated or not getting what they feel that they wish to have. So feel really positive about that. I think it's also important to note, though, we know, as Sadie has described, there are real pressures in primary care at the moment for a host of reasons, and we don't need to go through all those again now because I know they've been discussed before. But it was pleasing to note that comparatively, in September, Norfolk and Waveney had the second highest level of face-to-face appointments across the whole of the country. Of the 42 systems, we were second at just under 70%, I think. So that is pleasing to note. However, we absolutely recognise that there are real challenges for patients out there in some circumstances. So we must not and will not rest on our laurels. We will continue to work with practices to see what can we do to try and make things better for patients. So that's probably all I'll cover on that. The COVID and flu programme, the booster programme, is we're making good progress. It's picking up the pace, but for all the reasons that Sadie highlighted earlier, it is still very challenging, issues around workforce, but the teams are working extremely hard to make sure that those patients that need it do get their COVID boosters, their vaccinations and their flu injections, flu vaccinations as well. So as the report highlights, 33 practice clinics, 14 community pharmacy sites live. So we have good coverage across Norfolk and Waveney, but we still continue to monitor that closely. And finally, a couple of points. What we do recognise, and the report has highlighted, we are seeing coincidentally 55% of those eligible have taken up the booster vaccine at the time of writing, 55% for the flu jab for the over 65s, but the number is lower than we would wish in the 50 to 65-year-old age group at only 22%. So again, we're working with the comms teams, working with practices and teams to see how can we encourage people in that age group to come forward for their flu vaccine. So lots of hard work going on in those areas. So I would like to place on record my thanks to the team, many people, and to practices and nurses and other colleagues who are working really hard to try and make this a success. But so if I stop there, Doris, if I may, and then very happy to take any questions.
Thanks, Mark, for that update. And I think that the COVID vaccination, that those sites are in addition to the large sites as well, which we have a number of those. So there's quite a lot of coverage within Norfolk and Waveney that hopefully the general public can access to get the boosters. Andrew.
Yeah, hi. Just give you a bit of feedback that we've received through Healthwatch and so on about both those subjects. The one with the communication, I think it's really good that we're going to have a positive tone to it. And just to give you an illustration, I had a discussion with one of our local parish council chairmen. Now, obviously, parish councils have no particular power or with the health service, but they do represent local population. And I was really pleased. The tone they took was to say, how can we help? So although they were having problems with access for residents to a local practice, but they weren't really complaining as such. They were saying, what can we do to help you, which I thought was marvellous. And the other one, just quickly on COVID vaccinations, what I've noticed is there is some confusion in the booking system, in that we seem to have two parallel systems. Now, when I do a COVID clinic at Thetford, I probably speak to about 100 people a day very briefly, and most of them are confused, and I'm confused as well, because there is the overall booking system, and then there's the one that our practices and PCNs are doing kind of individually. And is there any way of deconflicting this and sorting it out, do you think?
Very good question. Thank you, Andrew. So the first point, that's really positive to hear. I do like the how can we help message. So that's really encouraging, and thank you for sharing that. Confusing, yes, I would echo those comments, if I'm completely honest. I think is there things we can do, was your question? Yeah, I mean, the easiest answer would be to possibly move everything to the national booking system, but we know that doesn't work for some practices. So we continue to try and streamline things, but also we know there's some messaging, there are things within our gift to do locally, but there's also an awful lot that is not within our gift, that is set nationally, and both in terms of communications and how we expect it to operate and run. We do try and feed back up the line some of the challenges that patients are experiencing, and therefore our teams and centres are experiencing in trying to do that. I would hope we can get better at this, Andrew, but it is very much a subject that we are looking at.
And I think changing in national policy has also had its impact, because suddenly, as of yesterday, the rules completely changed, and depending on whether you're quick off the mark to get onto the national system or you're not, and then you still get reminders from, you know, the two don't tie up, as Andrew has rightly pointed out, and I'm glad I wasn't the only one scratching my head.
Absolutely, Doris. And if I may just add, sometimes in terms of the instruction that comes to our teams, it's either immediate or immediate changes, or yesterday or very soon after. So it makes it really difficult to get the messaging right to support patients and teams as well.
No, I totally appreciate that. It's, you know, there's a moving target, and it does make, you know, teams on the ground who are actually doing the work very, very challenging. Peter.
Thank you. I mean, just to really welcome the information in the report and the campaign, and nothing that I'm about to say doubts the benefit of the campaign, and also in any way draws back from the hard work that's going on and the recovery position in terms of appointments in primary care. I do, however, just want to flag that a return to 70% of appointments being in person and being third top in the country, we shouldn't mistake as a signal of recovery of individual services. And I want to draw a link to risk PC11, and that those slots that are being filled by what once would have been secondary care activity, particularly from our point of view in public health, we'll have delivered through no one's fault other than the impact of COVID, but we will have seen the delivery of 36,000 fewer NHS health checks by the end of this financial year than otherwise would have been the case. And in partnership with the LMC and the LPC, we've had to go out to procure to find a temporary additional partner to help us catch up with those, because we do want to deliver those lost health checks. Because at the moment, despite 70% of attendances in person at primary care, we're not seeing primary care having the capacity to recover the health check position, as one example. And so it's brilliant work. I acknowledge how hard everyone is working, but individual services are still quite disrupted. Thanks very much.
May I come back? Sorry, may I come back? Thank you, Peter. I completely agree. I'm really pleased you raised it. So I should have perhaps mentioned that in my update as well. I think you're completely right. And it's just another symptom, isn't it, of the real pressure. We're a long way from over this, absolutely. But thank you.
Sue.
Thank you. I was just going to echo one of the points that Andrew just made, really. Only yesterday I was in Waveney chatting to a group of folk, and there was that element of confusion around the booster. It was an elderly lady that I was actually chatting to at the time, and she really didn't know whether she should wait for the GP, because she thought that she should be waiting for the GP to contact her about her booster because she was well due for it. This was the confusion. Or whether she should get one of her family members to seek the national booking system. And it was a little difficult for me to quite know how to signpost her, really, because she was very much under the impression that she should be waiting for the GP to contact her. But in the end I said, well, you know, if you do have to wait too long, then maybe you should get one of your family members to contact the national booking system, because I didn't want her to sort of go too long, you know, without having the booster. But yeah, there's certainly that element of confusion out there.
Thank you very much, Sue. Mark, did you want to come back in?
Thank you, Doris. Yes, if I may, thank you, Sue. So I think what's most important, that those that are eligible do get their vaccination. So I don't think there is a wrong route here. But what I'll take away as an action based on that feedback from Andrew, Sue, and others is that we'll try and help with some messaging via our comms team to try and make the confusing situation a little more straightforward for people. So I will take that away from today. Thank you.
Thank you, Mark. I think if I just may just say one more little thing on the back of that, there was an element of thinking that this lady may well have wanted a vaccination at home as well, which might have added a slightly additional complication. I don't know whether the National Booking Service is able to plan home vaccinations, is it?
I don't believe it is. I think it's just for the sites. So
yeah, so that one probably would. Yeah.
Understood. Yeah. Thanks, Sue.
Thank you.
Kathy?
Thanks. It was just a question about the health checks, really, and it may not be the remit of this committee, but when Peter was talking about commissioning an alternative provider to catch up on the primary care health checks, the thought that struck me is then we'll uncover a whole other load of unmet need, and have we got a strategy to manage that? And I'm guessing it's going to pile into the bottleneck that's called primary care. Yeah, I mean, I recognise we do have to catch up on these things, but it also made me wonder whether this minute is the time that we have to catch up on those things. The second question I had, which is using a personal example as an example for the system, is we don't appear to have a process for giving booster jabs to those people who are not suitable for Pfizer. So I'm not suitable for Pfizer, and I've been told to make an appointment with my GP, which clearly I'm not going to do because they're busy doing real stuff. But it means that people who can't have Pfizer can't currently get boosters within the system. So that may be another signposting issue we need to address.
So thank you, Kathy. So on the first point, I think, part of the Winter Access Fund and the additional capacity, I think that wraps into that. We need to double check that it is strategically and we're not missing anything. So we'll check that. And I don't have an answer on the booster for those that can't have Pfizer. So I've noted that as well, Kathy. I don't know if any one of my colleagues is able to answer that one for us, but but we've got Andrew and Sadie, so two offers. Andrew, thank you.
Let's start with Andrew. He's keen.
I'll do my best. This crops up every now and then as a question, and it is difficult. And the problem is that people are told different answers from different areas. And the one you were told, Kathy, about go and ask your GP is the default answer for absolutely everything, which of course doesn't help because I'm afraid they won't know the answer. We can't. In the vaccination centres, there is only Pfizer. There's nothing else available. So without wanting to get into your personal story, but it depends on the reason behind it. And if it's the reason often is misunderstood, because people were told earlier in the year that they could only have AstraZeneca if they had a previous history of severe allergies. And now the rules have changed, and it takes somebody who knows that to explain what the specific severe allergies are. And the problem is there's not many people who seem to understand it. The other point is if the answer to that is yes, that is the correct problem, then actually then the answer is people have to be referred to one of the allergy clinics, in other words, where they were seen originally, which would be a secondary care allergy clinic, and then they'll either have supplies of alternatives or a Pfizer can be administered with hospital clinical care available. So in other words, being able to deal with the subsequent allergic reaction that may or may not occur. But I don't want to go too much into the weeds, but there are some answers, but they're not widely known. That's the trouble. It is really difficult, this, because what's said nationally is different to what's said locally and what's understood by individual clinicians. If that helps. I'm not sure it does.
Thank you, Andrew. I think it does. Sadie, was there anything you wanted to add?
I'm glad Andrew went first. But I think just as a follow-on point, I think what we'll do is we'll pick up that explanation again and share it back out with GP practices through our weekly bulletin and FAQs, and probably what would be helpful is to share that process with organisations such as Healthwatch, who do support people who come asking for help and what have you. So we will pick that one up. Thank you.
And no doubt Andrew will be happy to provide his professional expertise to cast his eye over what is being said. I've just volunteered you, Andrew.
That's okay, you're most welcome. Do my best.
Thank you very much. If there's no other questions or comments for Mark, I'll move on. Thank you very much, Mark. That was very helpful. It's a helpful discussion. On to the locally commissioned service paper. which is for noting. I think Gina's joined us spot on time, not thanks to me, but I think you are more vigilant. Over to you.
Thanks, Chair. So yes, thank you for having me back. This week is just for noting, but there's a couple of bits I'd like to draw attention to. I won't go through it in key detail, assuming that most people have kind of glanced through the paper. The programme is doing really well on a really challenging timeline. We've had 5 specifications so far go through and be approved by the clinical executive. 2 have been to the LMC for consultation and have come back already with notes, which we're now going to start going through. And the other 3, 2 of which are with them, and another to follow later today. So the team are working really well and really hard to get these through, which I'm really pleased about. We have 8 more due to be delivered by the end of November. So 5 will go to the next clinical executive meeting, but 2 elements. A, trying to put 8 specs through 1 meeting is slightly unfeasible for the clinicians to appropriately review them. So we've made a strategic decision that we're going to submit 5 to the next clinical exec and then hold 3 back, which we'll look at the end of November. Partly because they're a little bit more challenging to process and we want to do it correctly, and partly just for overload. Those poor clinicians are going to have to try and get through everything on top of the day jobs. So they are the kind of timelines we're looking at. The engagement with practice has started and it's actually going really well. So we've spent the last couple of weeks going through and working with each of the localities and attending both their practice manager meetings and the clinical director meetings. As you would expect, we are being challenged quite heavily on this. It means a lot to practices for services to their patients and also the financial element. But the process we're undergoing is being recognised as thorough and quite robust, and therefore, although they are nervous about the process, they are quite understandably reassured by the 6 key principles that were previously approved and which we're adhering to. So that's kind of going down well. The engagement with the LMC is going well, I think. Nikki, I think hopefully you'll nod. We are now meeting regularly on a weekly basis and actually having some really good collaborative approach to these LCSs. And as we get closer to delivery, some of the nitty-gritty detail. So again, I'm really pleased that we're working on a collaborative approach to some of the problems. I must apologise because I'd put in the paper that the comms paper had gone to the LMC at the point the papers went out to attendees. Actually went out 4 days later. So they've only just received it, but we have agreed for a comms strategy that we're going to run as a CCG directly to our members, and that the LMC will run something alongside us because they have slightly different take, which as you would expect, to get the messaging through. So that's going well and we're continuing. So we've got 1 more locality to talk to, but they've all invited us back each month for updates and as a key detail goes through, and also the PCN meetings. So all the practices and the GPs are getting involved, which is thorough and good. With regards to the overall programme, we have our finance meeting beginning of next week to look at how things are stacking up for those services which have been going through the consultation and through KEC. We have costed those up and looking at it against the overall pot. So we should be looking at the overall programme to be commissioned still on target for December. We'll complete the service stratification this month in order to be able to kind of underpin decisions going forward. One risk I would like to flag is that because we have staggered the delivery to KEC of these specifications, then there is a risk that if we want to do some proper consultation with LMC, that those that are delivering to KEC at the end of November won't be processed in time for the December meeting. So what we may well do is have a proposal in principle to come to December PCCC, which pending some tweaks to the service specs should be ready, but there may well be a case of it's in principle as opposed to actual final sign-off, which was intended. But I just wanted to raise that now as a risk, which has come to light since I wrote the update paper. That's it for me. Any queries?
Thank you very much, Gina. It's really, it was really good to see such a lot of progress since the last meeting. And I think, thanks to you and your team for the work you've done, and also for the LMC for their input as well. And it's a challenging thing that we need to get through over the line, but it's really good to see progress. So thank you, and noted the risk, I think is a risk that we have to accept. But it sounds like you're all guns going, and it's great, really good news. John.
Thanks, Doris. And just to reiterate that I think it seems really good progress on a really important area that I know has been outstanding for a long time and no doubt consuming a lot of time and effort. So real thanks for that. Just wanted to pick up one comment in the risks section at the end, which talks about, it says, note that financial uplifts will be a cost pressure to the CCG. I just wanted to double check that, because one of the principles was obviously that we were looking to maintain the envelope, not reduce it, but also not increase it. So I'm not sure if we're saying there that there are cost pressures coming through that will be a risk, or saying that if costs increase as a result of this process, that will be a risk to us.
So the risk works around, so we are, for the first year, we are building in a baseline finance baseline with regards to costing, but we have committed clearly to uplifts for subsequent years. So that is where risk will be as far as the envelope goes, because we obviously have to uplift in link with normal costs. One of the areas we will be looking at will be to do with, get to the nitty-gritty, the kind of key details on item of service. So we've already worked very closely with James Granger, who's aware of the financial envelope, but it will not be increasing from what is currently in there. But there's going to be flexibility around item of service, which we'll have to build in.
Okay, thanks, Gina.
Are there any other questions for Gina? Nikki.
It's not really a question, it's more of a comment. I'll just echo a lot of what Gina's said. The reality now, of course, with the delays and pandemic and everything that's caused them, is that it's really challenging for all of us. We're trying to have a proper consultation process, which includes our subgroup that I talked about earlier, and also the Practice Managers Liaison Group, which is a group that represents all the localities, so that we get a proper view from various aspects. So it is challenging. We're doing our best. As Gina noted, we managed to turn around the first two quite quickly, didn't we, Gina, and get those back to you. But then, of course, Gina has the added time and challenge of looking at our comments, and that process may continue. So yeah, it is challenging, but it is really exciting to see that things are happening now.
Thank you, Nikki. Yeah, we always knew this was going to be a challenging piece of work that needed doing, and I think with goodwill on all sides, we should get it over the line. But we do need proper consultation and feedback from interested parties. So thank you, Gina, for your hard work, and we look forward to hearing from you in December with a paper for approval, which will be an amazing Christmas present. So thank you.
Thank you.
See you in December. I'm going to move on to item 9, which is the workforce and training report. I think Claire is going to join us with Fiona to present this paper. Over to you, Fiona, and I think, is Claire with us? She's here. Excellent, thank you.
Yes, thank you, Chair. Claire's going to talk to the training hub element of the paper, and then I'll pick up on the workforce paper. So Claire, over to you.
Thank you, Fiona. Thank you, Doris. Nice to see everybody. Assuming you've all read the paper, has anybody got any burning questions from the paper that was submitted around the maturity matrix in particular, which is from page 58, I want to say.
Kathy?
Hi Claire, and it's probably in there, but I've missed it. It's just last meeting, there was an item on access in primary care, and I wasn't at the meeting, but I noticed in the minutes that Fiona talked about the support that the training hub is giving to practices and PCNs to address access issues, and I just I wondered what form that support takes. Is there something about kind of learning sets and sharing best practice, or is it some other approach that you're taking?
Fiona, do you want to take that, or would you like me to take that?
So I think there's a range of issues, and some of them will be picked up in part 2 with the winter access funds that we're looking at, and particularly I think it's around where training hubs can support is around staff resilience, staff development and training to support access and make sure that that's working. Claire, do you want to pick up on that?
Yeah, so I think all of our programs and projects, we try and align to the improving access, improving workforce support for that, which is through the resilience and retention. So I haven't got anything specific for you, Kathy, in response to your question. Just that it's constantly under development. For instance, we are creating panels where we involve the patients, where we're learning from, and this is more to do with training, having a quality team piece of a collaborative project, which is our GPN development lead is heavily involved in, where we're creating panels where we're sharing best practice, learning from events, welcoming the patients and community's voice. So those panels are going to be in 2 parts, where we hear from the community themselves, and then we will hear. Then we work together as in an MDT approach to improve, go out and then take on board all that feedback from the panel and evaluate that, and then bring that learning back to the wider workforce on this has happened, this is how we evaluated it, and this is what could happen and should happen in the future sort of approach. So those sorts of things are happening. Very, very new. Obviously got to go through many governance processes. A terms of reference has got to be written, and working with other CCG directorates to ensure that everything is as it should be when you're creating those sorts of panels. But it's definitely under development, but nothing. I haven't got anything specific in response, so sorry.
Thanks, Claire. Does that sort of help answer your question, Kathy, or do you want to take Kathy?
It does and it doesn't. I mean, I may have not made myself clear. I can see that the workforce report is about, having enough staff and having staff with the right skills and having staff that are sufficiently resilient to be able to address access issues, which is the point. The point here. I guess what I was seeking to understand is the training hub, or is it not their role, to also work with PCNs around system and process? And by that I mean, within a PCN, you'll get some GP practices who are pressured but have a really great service and manage the access issue well. And then you'll have others who, for one reason or another, don't. I was wondering, is there any shared learning about how, the systems and processes that are there to manage access, which would then help with service, with service practice resilience? And so is that, it may not be the role of the training hub, but I was wondering, was that learning happening somewhere?
Fiona, did you want to come in? Because I think you put your hand up before I sort of asked Kathy for clarification.
Yes, I think I can add to that, and then I'm sure that Sadie's going to add to it. I think a lot of what Kathy is talking about is really important, and I think there's a real role for us sharing learning across the system. Obviously, the locality teams have an important role to play with this in terms of the work that's included in the PCN development, and then we need to pick that up and share it across the whole system, so that and then I also agree how we can support that through Training Hub, I mean, one of the initiatives that the Training Hub is picking up, obviously, is around the Accessible Information Standard. So we're rolling out a webinar in the coming weeks around that. So there are specific initiatives that Training Hub can pick up, but I think it's also wider than just Training Hub and taking that forward. But it's a really good point, and I think it's something we need to take away and consider. Kathy?
Sadie?
Thank you. Yeah, I think Fiona's touched on some of what I was going to say. So, for example, the workforce and training team support recruitment around the additional roles, lots of training, which, you know, is consistent across all of the roles. We've got the new fellowships and the new to practice schemes and the mentoring schemes such as the legacy nurses and things like that in supporting resilience and recruitment and retention. But then, as Fiona says, the sharing of best practice and what have you to date has generally been delivered within locality teams. But I think as we've now built our delegated commissioning team under Shepherd's leadership, and you'll have seen the resilience paper at the start of the agenda as well. As part of that, we're looking to share what's worked across teams, and Shepherd's team in the way it's worked with struggling practices and brought in almost consultancy support from and getting practices to support each other either within PCNs or through sort of direct arrangements. We have been sort of informally sharing good practice that way, but we're very conscious of the fact that we can do this better, and we can build up some resources there which we can share with practices. And now we've got a bit more capacity within the team. That's one of the things that we're looking to develop next, if you like. And to be fair to the LMC, they've been asking us to do this for a little while, around sort of how we build a resource around supporting practices, or almost like a document where we can find everything in one place, but we just simply haven't had the capacity to do that over the last 6 to 12 months. But it is getting now to the point where we think we've got the capacity to do it. So it is really important points. It's not necessarily just the training hub, although there are elements delivered by the training hub, but it is part of our overall primary care delivery.
Thank you, Sadie. Karen?
It's really, I mean, Sadie has summarised that, Doris, very beautifully in terms of it isn't just about the training hub, it's much broader about how the locality and the delegated team work together. But for me, it's about reducing variation. It's about understanding why there is variation across practices in terms of access. It's about sharing those models that some practices are doing exceptionally well with, and it's understanding what's the scope for those areas. So for me, there's a big key in understanding that variation and sharing it across the system, which I think we're getting into a position as we are more moving into business as usual, as Sadie says, having more bandwidth to be able to get back to looking at things like that. Thank you.
Thanks, Karen. And I think that's part of sort of the challenge as well, because different practices have adopted different digital strategies and maturity, and any communication piece. We need to be careful we don't confuse the patients who are with practices who are digitally immature, because they think, oh, I could go online and do this, and they go, oh no, we can't. So it's actually that consistency of access, so we don't have postcode lottery creeping in. I just wanted to ask a question of Claire in terms of the quality assurance, where it's rated red at the moment. Do you have any concerns as you know, turning that round to so it's not red rated?
Fiona, you were going to start. Do you want? I'm happy that we have a timeline and a plan in place. I've marked it red because we haven't got the current infrastructure there to support that program in the way that is required, but those roles are out to recruitment. We have a timeline in place to ensure that any backlog of work is completed by the end of Christmas, which means we can then really focus between January and March on making sure that we are where Health Education England would like us to be by year end. And having discussions with other East of England training hubs, we're not that far behind, which is very, very promising.
That's
Fiona,
great.
did you have anything else to add to that?
Thank you, Claire. I think you've described it very well. I think the reason why it's red is because of whilst these roles have always been within the infrastructure, and there's always been plans to recruit to those roles and replace someone who was in one of the roles. It's been brought forward as a priority because of the transfer of responsibilities from HEE to the CCG within a relatively short period of time. But as Claire's explained, we have got plans in place to mitigate that risk. But that's why we've highlighted it as red.
Thanks for the clarification. Kathy, your question's been answered.
Well, I had my hand up and then put it down again. I was just going to say that at the Quality and Performance Committee last week, I don't quite know which week we're in, we had a serious incident report, and one of the things that was really pleasing, even though it doesn't feel pleasing, is the increase in incident reporting from primary care. And it's not because they're having more incidents, it's because the quality improvement infrastructure is becoming embedded in primary care. So I want to just raise that here, and I think it's a tribute to the hard work of many of the people around the room that those things are actually happening. So in terms of that quality assurance piece quality improvement piece being red, I think there's a lot of work that is as yet, they haven't quite met the deadlines yet, but it feels really positive.
Thank you, Kathy. That's very helpful. I think, Fiona, did you want to take the other bit of the paper?
Sorry, thank you. Yes, I'll take the paper as read, but I just wanted to highlight really the additional roles in the paper. We have gone through a substantial exercise in validating the returns that came in from all the PCNs and checking and rechecking the information that they provided to ensure that identifying the unclaimed funding, as I'll call it for the moment, we were confident of what pot of money would be available so that we'd go out to the other all of the PCNs to bid for those monies. And I fully anticipate that all the funding is going to be committed by the end of this year, be in the region of about 10 million. We will have finished the panel to allocate the funding this week, so PCNs will know what the outcome of that is. And I think we are seeing quite a substantial increase in the care coordinator role, as I think the practices are really seeing that as a benefit, and certainly across winter to support them in that. And also to really highlight the importance of the additional roles in supporting the increase in appointment activity that's happening in GP practices, so that there's a real clinical skill mix that are seeing patients, and of course that links back into our comms programme about patients understanding why they're being referred to a specific individual and not necessarily a GP, and it's because that person is the right person for their particular care need. And I think the other thing I just wanted to highlight was the importance of developing a framework around the additional roles. I think there's some feedback recently around some of them being isolated within practices and PCNs. And what we want to do is obviously create that framework of support, partly through the fellowship programme that Training Hub manage, but also Training Hub are looking at other ways that we can support creating networks and that sort of support development framework around the R's roles. And I think that's becoming increasingly important as the number of roles expand. Other than that, I'm happy to take any questions.
Thank you, Fiona. Are there any questions for Fiona? I just have, it's for my lack of knowledge more than anything else, just to understand what the difference between the nursing apprenticeship, there's a 3 TNA, DNA, NDA and RNA. Just for those of us who are totally uninitiated on this, and Mr. Google couldn't help me either. I did try, but any clues? And the question I had really was in terms of, should we be encouraging PCNs to actually train, take people and train them rather than poach them from other organizations? And my own gut feeling is, would that not make it more sustainable? If somebody's had a good experience training with you, are they more likely to stay? Because we've always had this conversation, is sort of poaching from one organization to other. That doesn't seem very helpful. Sorry, that's it from me. Sadie.
Thank you. I only know one of those myself, Doris, and it's Trainee Nursing Associate. We might have to come back to you on the others with a bit of a glossary. In terms of the training, I think that's a really good point, and we are working directly with the with Health Education England colleagues to look at how we can increase learner placement capacity across our system. It's important to note that there are different levels of support for practices in place. So there's quite a lot of funding, for example, that comes with being a GP trainer, although it is a really significant commitment, and there isn't the same level of funding which comes with other professions. So, sometimes practices just physically aren't able to resource that level of capacity. We also need to bear in mind that the reimbursement rates for the additional roles scheme for the PCNs are quite set, and sometimes they just don't accommodate trainees in that. So Claire's team is working very hard on developing apprenticeships in general practice at lots of different levels to look at sort of supporting growing our own, if you like, and it is something that we recognise the importance of, and those that can train can probably recruit more easily than those that don't train, but there's quite a lot of complicating factors to bear in mind with it, but it's definitely part of our programme going forward.
Thanks, Sadie. These things are never uncomplicated, but it's it's that bit, especially where it is difficult to recruit to a particular area. If we can actually bring people in the community along with us, then surely it's a win-win, but maybe I'm being naive. Claire, did you want to come back in?
Thank you, Doris. It was just to clarify what the acronyms were and give a little narrative for everyone if it's helpful. So your trainee nurse associates are for general practice and PCNs who want to grow your own approach, which is the approach that we like to use in Training Hub, of your healthcare assistants and your healthcare support workers. So if you wanted to, their career development would be to be put on to a trainee nurse associate programme, of which is 2 years long. They will then become nurse associates, where they'll be on a register, but they are limited to in their capacity and competence of what they are able to deliver. I.e., they aren't allowed to do prescribe or cytology, those smear testings, although that's under big debate at the moment, because people can't understand why that nurse associate can't be trained to deliver cytology. And then the registered is again a registered nurse associate is just the next level of the nurse associate, as their competency and scope just reaches out a bit further. So it's just a nice career pathway, if you like, and a learning development trajectory of healthcare assistants, healthcare support workers, and other professions that may or may not want to come into the nursing fold. I hope that clarifies and makes sense.
Thank you, Claire. That's most helpful for those of us who are uninitiated. Thank you for that. Are there any other questions, comments for Fiona or Claire? No, thank you all very much for that report, and look forward to seeing you next time. Thank you. Thanks, Claire. We move on to the primary care network development, and is Ben joining us? I'm a couple of minutes early, so he's there. He's hovering. Excellent. Good to see you, Ben. Take it as read, and over to you.
Thanks, Chair, and good to see you too also. So yeah, we've tried to do this in a bit of a different format in terms of slides, so hopefully everyone's kind of seen the report and things like that, and I take it you've just touched on some of the additional roles and things like that. So there's some numbers in there per network for us, what we've managed to recruit and looking to recruit, and some of the spend and underspend and estimated budgets going forward. So happy to take any questions on that at the end, but I'll take that bit as read. But I wanted to pick out kind of 3 themes just around some of the PCN and place partners and collaborative working, and some of the vaccination bits in terms of community engagement, and some of the patient survey bits. So they were the 3 themes. So in terms of the PCN and place partners collaborative working, yeah, we really pride ourselves in Yarmouth and Waveney around this, and actually there's such a very close-knit team, because we're quite lucky we've got our own community provider and our own acute there, so we're actually work very closely together. So to give you some examples, we've got shared clinical systems to support referral and clinical dialogue, and that's very much capitalising on System 1 being our clinical system within GYW, and actually even Padgett are now starting to use some of that. So it's implementation of a co-designed piece, very much with our clinical directors from practices in mind. So they've actually designed this process where it kind of utilises the System 1 e-referral function. So there's no paper, it's purely a task through System 1 to enable that kind of notes and everything to follow that patient. So when a clinician logs on, all the information is there. So it's really quick, really easy, and actually saves clinicians a lot of time. So they don't have to track through bits and bits of paper. So it's really a good system. We held last week our first kind of clinical session with the James Padgett and the practices, and also our community provider EC, around some of the winter pressures in terms of actually how we're going to work together to go through the winter period, how we want to support each other with that same day emergency care piece, and came up with a number of schemes that we're going to try and look at over the next kind of couple of months, and also the introduction of the GP streaming at the front door of Padgett, which was introduced in September 2021, and has worked really well so far to help with some of that pressures across the James Padgett. But again, very much co-designed with our PCNs and our clinical directors, which is really key to kind of how then they feed into the system. So they're some of the things that we're really kind of proud of in terms of working together. There's 3 other scenarios in there as well. We're on health and wellbeing service, VCSE network, and population health management. But I'm only being told I've only got 10 minutes, so I'll keep it quick. And then the other bit I wanted to touch on was about the community engagement around vaccinations. So Great Yarmouth and Waveney. So we serve 2 borough and district councils within that. So we worked very closely with Great Yarmouth Borough Council around the vaccination programme. They actually received national funding up until March 2022 around a community champions programme, which has really helped us target some hard to reach groups within Yarmouth around ensuring that there's vaccination rates and uptake, as basically make sure that everyone has that offer. And there has been some challenges, and there still continues to be some challenges within that. But we are very lucky with Great Yarmouth Borough Council. There's been 80 volunteer champions that have been recruited so far, and they're very much embedded within the community and give us lots of soft intelligence, so we can actually then target them with the vaccination and educate and things like that, that enables them to also not just around the vaccination, but to give them access to general practice, to other services that they may not be aware of in the local community because of different thoughts and things like that around how people access healthcare. So that has worked really well. And the Great Yarmouth Borough Council have a kind of weekly meeting with our PCNs locally around the vaccination programme, about uptake rates and things like that, about how and then what areas they want to target, which is very data led with public health colleagues. So something very similar in the Waveney part. We've worked again very closely with East Suffolk District Council. We were awarded £70,000 following a bid from the Conf Award, and basically we've invested that into a community intervention team, and that's a very data-led driven team where they've actually targeted give you some numbers. In response, they've targeted 48 restaurants and takeaway establishments were visited by the team between the 16th and 20th of August. There are approximately 213 people working in these businesses with a 78% vaccine uptake identified, and 158 first vaccine, 155 second vaccine, and 9 books. So actually really being able to drive some of those numbers up in the Waveney piece. They targeted things like car washes and things like that as well. And there's some really good outcomes for individuals there. So I kind of wanted to paint some of that picture because actually it's really driven by the PCN and they want to kind of ensure that those uptake rates are good. The other bit I wanted to kind of touch on was the kind of patient survey piece. So I've done in the slides a kind of piece around some of our practices that requires improvement around CQC. And actually what you'll see, hopefully in the slide, is a bit of an improvement. There are a few numbers around high street surgery, around 2 of the markers that have decreased, but we are working with them around that. But overall, there has been a reasonable improvement compared to 2020 in most of our practices. And now the beaches have been rated good from a CQC perspective, which is also something that we're quite proud of within the area as well, because we work quite hard to enable that with the team. So I guess it's just trying to give an oversight and some flavour. It's very difficult to do in 10 minutes because there's so much work going on. That is a very quick whistle-stop tour, which I think I may have just done with a couple of minutes to spare. Happy to take any questions.
Thank you very much, Ben. It's always good to give you a challenge. You see, you're very knowledgeable about the area, and we need to make you concise. I mean, the slide pack is very helpful, and there's some really great information in there, and it's really good to see the progress that is happening on the ground, and especially the things that are happening in the community, and actually getting high rates of vaccination in hard to reach groups as well. So it's really good to see. So thank you. Are there any other questions or comments for Ben on the report and his Hein?
Thanks, Ben. I enjoyed the pack as well. And just to echo what Doris was saying, I really like those community engagement examples. I heard of some, but not all of them. So that gives comfort. What you guys are doing in that neck of the woods. Thanks.
Kathy?
what Hein said, but probably less eloquently. I mean, I really enjoyed the pack. I thought it was really informative, and I really want to congratulate you on the work that you've done for harder to reach communities, because I know from experience it's really hard work, and you've made great return on that effort. So well done. Thank you.
Thank you very much.
Shepherd?
I just wanted to say thank you, Ben. Very helpful, and it's really good to see the level of engagement with the community, and also to see the patient surveys. I'm going to just throw a challenge to you in terms of learning disabilities, because I'll be talking about it in the next paper. And in terms of patient feedback, how much is that representative of people with learning disabilities and mental health?
Thanks, Shepard. I don't know I don't have that stat off the top of my head, but what I do know is I know that the data piece only tells a certain element of the story. So there clearly is bits around this that we need to work on and things like that. And I would suggest learning difficulties is definitely one of those. But in terms of the numbers, I haven't got that. But there's something I could come back to you with. And I'm more than happy to kind of look into that.
Thank you.
John?
Thanks, Doris. Thanks again, Ben, for the update. Really helpful. So, just like others, I think it's really positive. Just wondering if there's any areas that you haven't been able to progress in Great Yarmouth and Waveney that you'd wanted to, and where there could be further support from any of us within the CCG team to help you progress.
Thanks, John. I think over the last 18 months, there's some things that have progressed beyond, recognition in the digital piece and things like that. I think it's just there is so much that we would like to do in terms of it's that prioritisation, isn't it? In terms of people bums on seats to be able to do it, and we can only work as fast as a general practice and also our other partners kind of, can go at this moment in time. So I think there's definitely more that I would like to do in terms of community engagement, in terms of actually really engaging with the population around health inequalities. And we're working very closely with Howard and the team, and we're very lucky to have Rachel Hunt and Shelley Ames in our team. But that's something that I think that's really taught me over this last 18 months in terms of the community engagements we've had around the vaccination piece. Actually, the gains there, actually, when you're going out to talk to people, it's massive. And it might not look that massive in terms of a spreadsheet, in terms of numbers and things like that, but it really is just I did a quick stint with a few people when going around and doing a few door knock-ins, and actually it was a very rewarding piece. And I think if there was something in terms of for the direction of CCG or ICS and things like that, I really think that could be something that we could do more of.
Thanks, Ben. I just had a couple quick questions. One was on the Lowestoft ARIS. There's a sort of slight overspend. Presumably that's going to be funded out of a budget somewhere. And on the PCN development plans, there's a couple of red rags. One was for Great Yarmouth and the villages, and one was for Lowestoft. Are there any concerns that causes you sleepless nights?
I think it just goes back to in terms of the workload and things like that. And we've just been very honest with this in terms of, so the slide pack that you see, we use this as a bit of a barometer with our CDs in terms of how progress is being made and things like that. So in terms of the red, I think that's more for us in terms of to try and push that along, because of capacity in terms of what's in the PCNs in terms of that management resource. So I don't think it's causing me any sleepless nights. I think it's just the volume of work that's happening at the minute, and those particular ones that are on Yarmouth and Northern Region and Lowestoft are red because of some of the capacity and some of the winter pressures we're facing. But it will be sorted in time for all the deadlines.
That's great. Thanks, Ben. Are there any other questions, comments for Ben? No. Thank you, Ben, for that report and update. And it's always good to see you. We'll see you in a few months' time. Thank you very much.
Thank you. Thank you. Good to see everyone. Bye-bye.
Bye. On to item 11, which is the LD health check. Shepherd.
Thank you, Doris. I guess I should say we are relatively in a very good position on learning disabilities annual health checks in a number of ways. So the first probably is from a governance point of view, that we have got the structures that we've set up in terms of having a task and finishing group in place, and also having a system-wide delivery plan that we are following, and also the localized plans that the locality teams are delivering on. I guess for the last 3 months, the key kind of progress that we have made is data is flowing through the system. So performance information is going to the locality teams, and it's filtering to the practices. And it's fair to say the conversations are live in the system, and difficult conversations are being held in terms of balancing those priorities amongst other clinical priorities. So with that, I'll take you probably just for you to see on the numbers that you have as evidence of data flowing through the system. So you've got a chance as well to see that data. I will draw your attention probably to the first table, which shows the regional performance and point to the fact that we are looking at data from April up to end of August. So you should expect further improvements as we look into September, which will be available for you in December. But you can see that our system is not far away. It's performing relatively the same as other parts of the system. But it's fair to note that our performance is improved from before. And if we go across and look at the bar chart, I think just to focus on the Norfolk and Waveney, and looking at Q2 and in orange there, you can see that actually we have improved from the previous quarter, which is positive. It may look small improvements, but actually they're very encouraging to me, because a lot of energy and passion, I feel it as I meet with different teams and different localities within the task and finish group. I'll take you to the next table there. And I think what I would like to do is just draw your attention to the performance that the Norwich locality is at. You can see that they're performing quite higher than other parts, and the drivers for that will be the investment that the CCG has put in that particular area, and also notably the leadership that I would say Emma and Jade are leading in that area. So the additional resource is something to note there. And equally, I would like to highlight Great Yarmouth and Waveney. And I think you've heard from Ben. I think the level of engagement with the local communities seems to pay dividend in that particular area. The other three remaining localities, they are working hard, and we should start seeing more visible improvements as we get into Q3 and also into Q4. So we are in a relatively strong position to be able to land at 75% of the national targets, and even more, I think, in other localities. And I think this just gives you a snapshot, and I don't think it represents, or I've probably given justice to the hard work that actually happens on the floor, but there is more that could be spoken about. I will stop there and take any questions or comments or any challenges from colleagues on this.
Thank you, Shepherd. It's really good to see some data and by locality, and also by the region as well. So, Kathy.
Thanks. Thank you, Shepherd. I mean, obviously I was here at the beginning of this story, so I'm aware of the amount of hard work that's gone into cleansing the data and actually getting something that looks meaningful on a page. So that's really fantastic, and well done to you and the team. And I really like being encouraged. However, I wondered about the level of assurance. I mean, it's reasonable to assume that if somebody's managed 21% in Q2, then they may reasonably reach 75% in Q4. But I'm just wondering whether we have a kind of a trajectory that gives us assurance around that for all of the different geographical patches. And then my second question is, while I recognise this report is about the numbers, I'm always worried about numbers in isolation because there's a chance of hitting the target and missing the point entirely, which is about providing quality health checks. And I wonder if you could also update us on the work stream to improve the quality of those checks as well as the numbers. Thank you.
Thank you. Very relevant questions, and that I will try and respond to. So in terms of the trajectories going into year end and looking at where we are, I think it's fair to say across the system or across the country, the LD annual health checks, there is a pattern in terms of these being delivered in Q3 and Q4, and in particular in Q4. So there's that prioritization that we can see across the country and also in our own system. But there is a lot of work that is taking place in terms of local prioritization. For example, in Norwich, they have moved to actually doing annual health checks by date of birth. And that has been shared with other localities, and they're actually being implemented. We just need to confirm in our task and finish groups. We've got the meeting tomorrow. And also, if we look at the West Norfolk, they had a meeting with the local LD team to actually agree to how to accelerate the performance there. They're quite challenged, but I think those conversations are live and happening in there. There is a lot of, I would say, conversations taking place, and they're live, and the passion and the energy, I think, is quite strong with colleagues leading on this. So each locality is represented, and the attendance in the task and finish group is very high, and the engagement is very strong. So I'm quite encouraged by the fact that we are talking about it, we are having difficult conversations about it, and it's constant and it's relentless. So I think I would leave that encouragement. It will grow into the results that we need. Regarding the quality of care, the quality of care, I think we have the dedicated team in Norwich that actually are focusing more on the quality and challenging the system. And it's well written in our delivery plan. The emphasis is there. So in terms of principle, that is there. In terms of the commitment is there. Where we need to test it is actually on the evaluation of quality, and that is a stage to follow.
Thanks, Shepherd. John.
Yeah, thank you. I was going to ask a similar question to Kathy, actually. So just building a little bit on that, I think thinking about the trajectory and the actions, I suppose, Shepherd, and you've talked a little bit about some of that and the fact that historically more checks happen in Q3 and Q4, but conscious of some of the conversations we've had earlier in this meeting about the intense pressures on general practice to maintain access, to deliver vaccinations, to do all the other things that are out there, it feels more important than ever that we actually have some definitive plans so we know actually what is going to happen and what will make a difference. So just looking at the raw numbers, if you like, West Norfolk have averaged about 6 a week, April to August. They need to do about 25 a week, 30 a week between now and the end of the year to get to 75% delivery. So that's quite a step change. That's quite a difference. And I suppose it'd be really good to know what are the key actions that are going to happen in each patch to make a difference. That's not necessarily something to answer now, but I think I just want more assurance on the fact there are plans underneath it, as opposed to clearly goodwill, which is really important, but actually what's that translating to in terms of definite actions?
Absolutely. And I think more will be answered probably at the next meeting. But what I would say is we are pulling together every opportunity to actually put this at the top of the priorities for the practices, amongst other challenges. And one of the things that we are encouraging the practices to do is to look at how they could align some of the funding that we will be offering around resilience funding, because we do realize that SMI LD will take a lot of pressure or will put the systems under pressure, and we are encouraging practices to actually think about that, and when they're applying in the resilience funding to actually consider that. So there will be opportunities that would help practices to remain resilient and also deliver on this. I also know that under the new additional roles, one of the localities are actually looking at LD and SMI as a priority. And if they're successful in that, that would also strengthen our position. So loads of conversation taking place, and we'll start to see those coming into fruition maybe in Q3 and Q4.
Kathy, did you want to come back in?
Sorry, it's just a comment really, which is sometimes the simplest things are the kind of aha moments. And when you said that Norwich locality is doing them by date of birth or thinking about it, it struck me about why I'm so worried about this, because if something's a priority, you don't shove everything into the end of the year. So actually spacing them out over the course of the year makes more sense, doesn't it? And it suggests that there's more of a focus on quality therefore. So thank you. That was an aha moment for me.
Thank you.
I just had one question in terms of where the health checks were declined. Do we understand why they were declined and whether there is anything that can be done to encourage people to take it up, whether because they've had bad experiences in the past or whatever, whether there's some learning coming from those?
I'm equally curious, Doris, and I'm really interested in that. It's a question that I asked myself when I saw the data, so I would need to come back to you on those ones.
Thank you very much, Shepherd. Karen?
I think that's a really interesting point. I think it's important to collect the views of people. Several years ago we did this, and we invited a number of people with LD to one of our governing body meetings when we were historically 5. And they told us very clearly some of the issues, and it was about being given sufficient time to express themselves, to make those reasonable adjustments. And I think it'd be really good if we did some co-production work with our engagement team, our comms team, Paul's team, to really support Shepherd and his teams in what's going to work well for those individuals. Because it is about getting the right environment and having time to be able to speak and express yourself.
Thanks, Karen. If there's no other questions, comments, no, thank you. Thank you, Shepherd. That was very helpful, and we look forward to the next update and continuing progress in this area. On to the prescribing report. I think Jess is joining us. She is here.
Hello, yes, I'm here. Okay.
Over to you. Take the report as read, and anything you want to highlight to us.
Okay, so if we just go through a few points on the report. So we still remain at the 5th highest spending area across the 12 CCGs in the east of England. And as we always point out, this doesn't take deprivation into account. Cost pressures are still there. What we're now seeing is that a lot of the concession prices and the NCSO items are going back into the drug tariff, but at a higher price. So we're seeing these pressures displaying in a different area, and you'll see from the report that the concessions are dropping in value, but the higher drug tariff prices are increasing. So that just needs to be noted, that that's still pressure. There is still pressure there. Then if we go to antibiotics, I'd like the committee to note that overall antibiotic prescribing did slightly increase from April as people started going out again, but that has now started to drop again. So that's good to see that we're not returning to previous levels of antimicrobial prescribing before the pandemic. New measures were brought in this year to meet the national target of reducing antimicrobial prescribing by 25%. And you can see from the chart on page 87 that all of our PCNs bar 2 are reaching that new stretch target. With regard to our outlier practices, I'm really pleased to report that 2 of our target practices, Bridge Street and Howdale, have dropped out of the top 12 outlier practices in Norfolk and Waveney. So that's really, really pleasing to see. And just to point out, this month is Antimicrobial Awareness Week, and we're working with the comms team and the quality team to get messages out to the public. Any questions?
Thank you very much. Jess, any questions from anybody on the report? John?
Yeah, just one, Jess. So whilst it was really pleasing to note that a couple of the targeted practices have dropped out, there's some that seem to be in there right at the top every month, and I haven't checked back, but it doesn't feel like there's been much movement with them. I'm sure that's not because of a lack of effort from the team.
Yeah, so one of them we are really struggling to get engagement with. The other one, we are actually carrying out their audit at the moment, so we have got engagement there. And we are still in August data, so
I suppose it'd be useful to know maybe offline if there's any other support that could be given with practices that aren't actually engaging, because this feels important clinically. So yeah,
no, that would be great.
Good to know so that we could support.
Thank you.
Hi.
Yeah, thanks, Jess. I have a few detailed questions which I'll send by email offline.
Okay.
But one specific point in paragraph 3.4 is reference to a presentation to the clinical exec committee a couple of months ago and a series of recommendations. Could you share one or two that seem to hold most hope or most impact?
Yeah, can I share those offline? I haven't got those to hand at the moment, but yes, I will do.
Thank you.
Emma?
Thank you, Doris. It's just in response to John's point that he raised earlier. As a team, our finance and obviously management colleagues are working together to look at prescribing efficiencies. What we're starting to do is to look at the correlation between practices that have got clinical pharmacists from their ARS scheme working with them and the practices that haven't, to see what impact that may be having. And for those practices that haven't, looking at whether those roles are scheduled to be recruited to, so we can see what, if anything, we can do about engagement further, both embedded within the practice and ourselves, reaching out as a CCG.
Thank you, Emma. I just had one question in terms of the prescribing quality team. Are we expecting the remaining 2 practices to sign up, or has they signed up since writing the report?
Yeah, so one has signed up since writing the report. The other one, I'm still trying to get a reply from. I think it's a lack of response rather than a lack of wanting to actually participate.
Thank you. Are there any other questions, comments for Jess? No, thank you very much, Jess, for that and for the report. Thank you.
Thank you.
On to the finance report. Emma, I think you're here to give us the highlights and lowlights.
I am indeed. Thank you, Doris, and good afternoon, everyone. I'll take the report as read if I may, but I'll just provide the highlights to the committee. So the month 6 finance report presented to the committee shows a overall broadly balanced position against the H1 budget, with expenditure equating to 198.8 million for the period of April to September. Within the total primary care portfolio, there are, however, net overspends from GP prescribing, as we've just been looking at with Jess, and this equates to 1.2 million from price, from volumes, from our anticoagulants, and further exacerbated by reduced efficiency savings as a result of vacant roles within the meds management team. It's worth noting that this overspend is after a non-recurrent prior year benefit of £1.5 million, so there is significant pressure in this area. GP prescribing has also benefited, however, from underspends within central drugs, dressings and wound care. The total position, as I said, is balanced, and that has partly been mitigated from underspends within other primary care to include delegated primary care portfolio of 0.4 million. And this comes predominantly from the reduced volume-based Norwich Walk-in Centre, reductions in locums and rent costs, and another prior year benefit of 0.3 million. It's worth noting in the half-year position that we have got higher levels of costs and budgets for our quality outcome framework and also for our additional roles reimbursement schemes. And this pressure continues for the remainder of the 21-22 year. This pressure arises from late and updated guidance from NHSEI around indicators for which we're payable or roles higher than the initial guidance issued when the budgets were set. So it's been covered, that risk at the moment, from the benefits in delegated primary care, the net benefits, and overall we are balanced, but say we have continued risk from our GP prescribing, which aligns with messages that Jess has just been sharing with the committee. So any questions, if I may, please?
Thank you, Emma. Any questions from anybody? Hein.
Thanks, Emma. I was wondering, is there any update on the H2 funding picture and implied efficiency target was 5%? Seems like a very high number to attain.
Indeed. So we do have some draft budgets in our month 7 position, which will be shared with the committee next month. They've not been finalised, but obviously as a CCG, we're still looking to retain a break-even position. Within the primary care portfolio, to include delegated primary care, we have put some additional funding in, particularly to recognise the increased pressures in GP prescribing over the winter period. However, that's almost fully negated by challenges around efficiencies. So we have efficiencies in excess of £2 million in the GP prescribing element for the second half of the year. So broadly consistent, but we'll certainly be laying that out clearly for the committee next month to look at the difference between the H1 funding and position and the H2 draft funding position.
Thanks, Emma.
Thank you.
Thank you for that heads up for H2, which we're obviously in already. More challenges to come, I think. Any other questions for Emma? No, thank you very much, Emma, for the update, and we look forward to finding out what the second half brings. Maybe we need a cold towel at that point, but hopefully not. Thank you all very much. I don't think there's been any questions from the public prior to the meeting, unless any's come in since we've been meeting. Noah, I think, welcome from the EDP.
Hello, yes, I had a public question, if I may.
Yep.
Might be best placed with Mark or possibly someone else, but I just wondered if slightly more detail could be given about the rollout of the COVID booster and flu jabs. In Norfolk, you mentioned workforce issues. I don't know if slightly more detail on the nature of those could be provided. Anecdotally, I've heard suggestions of possible supply problems too. I don't know if anything could be said on that possibly.
Thank you, Noah. Sorry, apologies, struggling to get my mic unmuted. So workforce, and I'll invite Sadie and others to join as well. I think there's two things going on here. Firstly, we know workforce is stretched across all sectors of the health sector, but also with the impact, as Sadie highlighted earlier, around isolation, children testing positive for COVID and then having to isolate as a result. And we must remember that in primary care, their ability to flex is limited. They're not massive teams. So 1 or 2 people out from a stretched team does cause significant impact, Noah. So that's that point. And you mentioned also about supply challenges. I know early on in the campaign around, not so much about boosters, but we know that there was some delays to delivery to some flu stocks early, but I think that's been resolved now. But colleagues on the call might be better placed to answer that than me. I think I'm speaking accurate fact, aren't I? Yep, getting nods from Sadie and Karen. So does that help, Noah?
Yes, no, that's very helpful. Yeah, thank you.
Great, no problem.
That's great. Thank you all very much for this afternoon's attendance and contributions. I am going to close the meeting. Oh, Sadie, did you want to come in?
It was just a comment unrelated to the last point because Mark covered that off, but I just wanted to mention that there's an error on the agenda. The next meeting should be in people's diaries for the 7th of December, not the 14th as it states on our agenda. So just wanted to make that clear. Apologies for that.
Yeah, otherwise you turn up on the 7th and there's nobody here. Thank you very much. I think with I think being December, things got shoveled forward, didn't it? So yeah, good spot. Thank you. So thank you all very much for your contributions this afternoon, and for those joining in part 2, we'll come back in 10 minutes just to give you all a bit of a break. So 15:25 according to my computer. Thank you very much. Look forward to seeing you all in a bit. Bye.
Bye now. Thank you.